This conference will now be recorded.
Okay, so I've got two cases today. This is the first one. So on the CT chest, we can see as we sort of come down towards the bases of the lungs, there are some areas that look like fibrosis with some reticulation, as well as these more well-defined sort of larger cystic spaces down at the bases that look sort of almost like emphysema, but with more walls to it, right? Thicker rims around it, as well as some areas of ground glass on top of it. So if I were presented with this and I was reading this, I would probably call this what looks like a fibrotic DIP, discriminative interstitial pneumonia pattern. And I would suggest correlation with any smoking history. However, this is a 45-year-old woman who has no history of smoking whatsoever, including no secondhand smoke exposure. And we can actually see the patient came back 5 years later and got another CT, and we see even more of this really extensive areas of cystic destruction at the lung bases with sort of fibrotic rims to it. And some of that ground glass is still there, although there's less than there was previously. So again, the imaging looks to me like sort of fibrotic or burnt out DIP, but with no smoking history, it's a little unusual. But this patient does have limited scleroderma, so has connective tissue disease. And so, while this is obviously not the most common pattern that we see in patients with connective tissue disease, we do occasionally see patients whose lung disease in connective tissue disease presents as a DIP pattern rather than the more classic sort of NSIP type pattern. And a couple of the pathologists at our institution actually published on a couple cases, not including this one, this one's new, that they had of connective tissue disease patients who presented with both radiographic and histologic DIP, as well as other histologic patterns.
So Maya, I've not heard the term fibrotic DIP because when you first started showing this, I wondered if this was this airspace expansion with fibrosis that we see in
Mhm.
smokers, where
Mhm.
you get emphysema colliding with fibrosis. You get these thick-walled cystic spaces in these a little bit, not necessarily that, like on your first scan, more posterior, kind
Yeah.
of lower lobes. Um, so yeah, I'd love to see that paper they published on because DIP
Yeah,
is such a rare,
Could you
somewhat controversial histology.
totally.
could you send us the reference on that? That would be great.
Yeah, definitely. It's an older paper, so I don't know how accessible it is, but I definitely can send you the um, link
That's
um,
perfect.
to it.
Thank you.
Yeah,
So,
absolutely.
I would, there's not a whole lot of fibrosis in this. Most of the walls of these big spaces are very thin. So, I mean, I think you could call this like paraseptal emphysema.
Hmm.
Um, and all it takes is macrophages to digest the lung. We had a recent case where it looked like your case here, except that it was flipped. The stuff was developing at the apices. The person did not have any known autoimmune disease, but
Hmm.
had this progressive, paraseptal emphysema or like these peripheral bullae, whatever you want to call it,
Yeah.
going on. But it was in the upper lungs and it was kind of mysterious. I have seen that in response to infection sometimes, where a whole lung becomes emphysematous in the course of an infection. Initially, normal lung got infected, left upper lobe, and then we're left with profound emphysema. So all it takes is macrophages to be activated for some whatever reason, and then they digest the lung. So
Definitely.
yeah, it's a macrophage disease basically.
Cool.
So is DIP.
Yeah, exactly. All right. And then the other case I have is this one here, which is an entity that realistically I don't know that I would have ever called this prospectively. Um, But let's see. The first imaging we actually have on this patient is this PET CT, which is from back in 2022. And obviously, there's a lot of respiratory motion, but even on this PET CT, I would argue that there's definitely some interlobular septal thickening, particularly up at the lung apices, pretty extensive, as well as some areas that look like superimposed ground glass. And as we come down to the bases, it looks pretty normal. Um, The patient then, a couple months later, got an actual diagnostic chest CT, so we can see this in a little bit better detail. Again, this really marked thickening of the interlobular septae, some of which almost looks a little bit nodular, as well as all of these areas of what look like discrete ground glass looking nodules and some areas of cysts, some of which maybe have some associated little nodules with them. So this is 2022, and then I'm just going to speed ahead because realistically not a whole lot changes. This is now almost a year later. Same patient. This is what their CT looks like. And again, a lot of thickening of the septae, a lot of these sort of irregular, almost looking cysts. Again, a couple of them have little nodules associated with them, but not much. And then again, some of this ground glass looking stuff superimposed, little nodules up at the lung apices. And again, not much going on at the lung bases. This patient has no respiratory symptoms. This was an imaging finding. And the history that I have not given you is that this patient has multiple myeloma. And so this patient eventually underwent, I think, surgical biopsy of the lung to figure out what this was. It may have been transplant, I don't remember. They underwent biopsy of the lung, and the pathology came back as alveolar septal type amyloid.
Excellent.
Which again is just not a pattern that I have seen before, but this seems like what it's described
we
as.
can explain with that. Yeah,
Yeah, definitely.
It's interesting that it's so strikingly upper zone. It sort of fades out at the bases.
Yeah, great.
I think there are some reported cases of septal amyloidosis that are upper lung predominant. So, normally we think of amyloid, but the nodular pattern seems to be worse in the bases, but the
Right.
interstitial form doesn't have to be in the bases.
Yeah.
That's cool.
So yeah, I know it's
That's
just a
very
cool case of something I've not
Damn
seen
you,
before.
light chains.
I know, right? Yeah. All right, I will hand this back and I will put the link to that paper in the chat in just a minute.
Well, thank
Great
you.
cases.
Thanks.
Yep. Do you have anything, David?
Yes, I do have some.
Perfect. Let's see.
Let's see. Let's entire screen. I guess we'll go with entire screen. Okay.
All good.
Okay, so I hope you can see a chest radiograph with diffuse lung disease and low lung volume.
Yep.
So this is a leukemic patient, and this was a few weeks before his chest radiograph got a different sort of abnormality. We began to develop this blob here in the right mid lung. This is an immune compromised person with neutropenia. So the first thing you think of with a nodular new lesion is fungal infection. And so this led to CT, and indeed there is a nodular lesion with kind of a lacy interior, not a very well defined rind around it, but not a bad pattern for mucor. That bird's nest pattern is the dense periphery and then the kind of lacy interior. And this turns out to be mucor. Indeed, this is Rhizopus microsporus, which is one of the mucor species we see commonly. And so the treatment was lobectomy. This person got right upper lobectomy and has survived that, has lots of other complications, is still in the hospital at this point. So that was a case of mucor. It caught pretty early here before it got to be a very large lesion. This person's chest radiograph was normal 2 weeks before and now has this round lesion, again with a necrotic center to it, and has a smaller lesion actually on the other side too. This is also, this was an MDS AML patient with neutropenia and had this new finding, which alarmed people, and got a CT scan. And here we have this very necrotic large lesion here. And it's not bird's nesty. It's a necrotic center. You know, the mucor, it has this lacy center that looks as if it's almost preserved lung. It also looks like venous infarcts. You know, the mucor lesion, I wonder whether there actually is a case of venous infarction. We know that that mucor is angioinvasive, so is aspergillus. I always presumed that somehow meant invading arteries, but the veins can be invaded as well, and that's why a lot of those lesions, the bird's nest lesion, really does look like a venous infarct. If you told me that the person had left atrial appendage ablation and they took out a pulmonary vein, and you got a peripheral lung lesion, that looks a lot like mucor. Anyway, this turns out to be Aspergillus fumigatus with these two lesions. So it's a necrotic center, but it's a different pattern of central necrosis from what we commonly see in that bird's nesty mucor. Okay, so then this person has a round lesion in the right upper lobe with necrotic looking center, definitely not normal, and is not really having any symptoms from this. So this is kind of surprising. This is not a stem cell transplant patient. Person got a CT scan, and let me give you a better lung window. Here we have this consolidation with air bronchograms, which I believe is rare in fungal infection to have nice air bronchograms, and does have that sort of center of, preserved looking lung here. So this doesn't look as aggressive as a typical mucor lesion, although it does have lots of bird's nest features here, but does have air bronchograms, which Jeff may disagree with me, but I think air bronchograms are not that common in fungal nodules. Now, Jeff is a specialist in blastomycosis, and that often looks like a bacterial pneumonia, so I'm going to cross blasto off my list. But the fungi that we see out here, rarely have air bronchograms. So I'm going to state that categorically.
I'm going to agree with you on that one, especially when it's like a mass or a nodule.
Right. Okay. Super. Okay. This is bizarre lesion, and the person's not very symptomatic. So I was trying to think, this person has a history of autoimmune disease and has probably been on some immune suppression off and on. And so I was wondering, could this be something like nocardia? This would be great for nocardia. The lesions tend to be in upper lungs. You don't have to be very compromised to get nocardia. It evolves more slowly. It's not as aggressive as aspergillus or mucor. So I thought this would be great for nocardia. Okay. So it turns out that this person, I'm going to see if I can bring up some other scans here. This person has had a variety of abnormalities on previous chest radiographs. So I'm going to go back in time here. Here is an earlier study now, months ago. And at this point, the person had these vague ground glassy patches in a couple of different locations here. This person has two things. One is CVID, has IgA deficiency, and also has an ANCA-positive vasculitis. So this really looks like organizing pneumonia, and lesions like this have come and gone several times. And there was even one chest radiograph, which I don't have ready to show you, that looked a little like our current chest radiograph with that right upper lobe lesion, except a fainter lesion was present on the left at that point. And so this really turns out to be, and this person has had biopsy, had lavage, and there was no infection, has had lavage a few times, including on the current round with that distinct right upper lobe lesion. And in the lavage they got about lots of lymphocytes back and some neutrophils and stuff like that. So they're calling this organizing pneumonia. So that big aggressive looking lesion looks more aggressive than organizing pneumonia that we usually see. It's very discreet. This was the only lesion present currently. Looks a lot more horrendous. I would really hesitate to call this organizing pneumonia right off, just given how very firm it looks and stuff like that. I said, you really have to rule out an infection on this case. And it turns out this is organizing pneumonia, and the person's had it before. So this is all related to the ILD, the ANCA positive ILD, however they're characterizing it, and the maybe the mild immune deficiency from the IgA deficiency, for which the person gets periodic transfusions of immune globulins. So I've shown you 3 right upper lobe lesions, mucor, aspergillus, and what I thought was going to be a fungal infection or nocardia, which turns out to be related to some sort of organizing pneumonia from ILD. So let me show you one other case that's more straightforward. There's a faint lower lobe consolidation behind the heart here, and this is has a distinctive finding on CT. So here's our lesion on CT, and it does have this low attenuation stuff here component to it. So let me show you that with it is a fat containing lesion down here, and this person does use mineral oil regularly as a laxative. So this is a mineral oil aspiration with nice lipid deposits here matching the density of the subcutaneous fat here. So this is exogenous lipoid pneumonia down here. And let's see if there's any on the other side, because aspiration is often bilateral. Okay, so mineral oil aspiration.
Nice.
Okay.
So David, I decided your big fat atoll is just, from the olden days before there was this rising sea levels and the island
That's
was
right.
much bigger.
Yeah. Yeah.
Before we started
Okay.
using all this mineral oil and warming everything up.
That's right.
Yeah. But yeah, I think you're absolutely right about that. I've not seen histo. I mean, when blasto is a mass, it usually looks like a nasty lung cancer, and you might see little cavitations, but you don't usually see much in the way of airways. But like histo and the cocci cases we see, which we see a fair number because they all come back here after spending the winter down in the Southwest. We just had one yesterday. I don't recall seeing air bronchograms in any of those lesions because there's so much inflammation. It's not alveolar filling, but just it's a big inflammatory process. Whereas organizing pneumonia is just airspace problems with maybe a little bit of inflammation in the interstitium. So it makes sense that
Right.
the airways themselves are preserved.
Right. Got it.
But yeah, that is probably the thickest atoll I've seen.
Yeah.
Agreed.
Yeah.
Yeah. Well, okay, cool. Alrighty, so I've got 3 cases I can share here. Let's see, make presenter, share, I'll just share the screen. Alrighty, you should see a CT scan. And so this is a patient with a known cancer.
I don't think I'm seeing it, Jeff.
Really?
I can see it.
You can.
Yeah.
You
must have
okay.
paid your electric bill.
So you do see my CT.
Yes.
Okay. So this patient has a cancer and has all these blobs in the lungs. And the reason I'm showing this case is because what these blobs look like, let me get the right window here, is you can see they have some mineral or something in them. And so this is not a common tumor in adults, and it's not a common appearance of the metastases to see this, but any guess what this patient's primary cancer is? Got this amorphous looking calcium in it. This is probably the best example here. Sort of cloud-like.
Jeff, I still can't see it, but is it Psammomatous calcification?
No, it's more amorphous cloud-like calcification.
Any chance you could share again? Because
yeah, I'm gonna try that because it's weird. Some people are seeing it and some aren't. How about now? My crew sees it. Do you, David?
No, I do not.
It's good.
I still see it. So here for me.
All right. Well, anyway, this is metastatic osteosarcoma with actual bone matrix informing in some of the metastases. Usually they de-differentiate and we don't see much. I've only seen a handful of cases over the years, one to the pleura that kind of left this calcific rind. But these are obviously very big metastases. But I just want to show those because the matrix in there is very helpful in this case if you didn't know the history. This is probably the most interesting case I'll show today. So this is a patient who has known echinococcal disease. And for lung echinococcal disease, they typically resect the lesions because the pharmacotherapy doesn't work well in the lungs. The liver ones they can treat. So here's a very typical echinococcal cyst. It's water density. It has really no material associated with hanging out in the left upper lobe. But this patient was coughing up some blood. And you can see this one down here doesn't look so nice. It's got air in it, and it's got all this dense stuff, which turn out to be vessels running along the walls. So the air has to get in there it has to rupture or into the lung to get air in there. And we don't see the collapsed endocyst, and normally these are avascular. So what's happened is this one has gotten super infected at some point and probably has a small leak in the lung. But what's really cool is if you look at this uh, inferior phrenic artery coming off the aorta. At first, I was trying to figure out where this vasculature is coming from, but it's recruited this artery all the way from coming from here off the celiac, running behind the cava, going along the diaphragm where it's supposed to go, and it's decided to send off this big branch to supply the diaphragm, and it has recruited it into this infected echinococcal cyst. Also, interestingly, if you look, there's big bronchial arteries also going into this thing. So it's got a dual systemic blood supply, presumably because of chronic infection. So, of course, this is at risk for continued bleeding and probably, I mean, you could embolize it, but it really needs to be resected. So an infected echinococcal cyst. They don't usually get infected too often. They usually just rupture if they don't treat them. And yeah, so very unusual. But I've never seen one get this kind of degree of systemic circulation. All
Jeff,
right.
how do you think it gets into the lung? Normally these things are, they're adjacent to the liver. They erode through the diaphragm, be in the pleura, and get into the lung
Right.
that way. But these seem to have sort of hopped into the lung, not not tracked into the lung. How,
Yeah,
you know,
it's funny. I've seen a bunch of these, and I've only seen one ever that also had coexistent liver disease. So I don't know
mhm,
if it's a separate route, um, if it gets somehow into the systemic venous supply as opposed to the portal venous supply. That's the
got
only
it.
thing I can think of. Usually because they're ingested and work their way out, unless they're aspirated um, after getting in the upper aerodigestive tract. Um,
I
but
like your idea. I think it got into systemic venous return, and
that's what I
then
suspect.
yeah, so it's really
Because even
bloodborne.
though the gut drains to the portal system, I think there's some systemic venous drainage too. And that, yeah, like I said, I've not seen a lot of coexistent liver and lung disease, but yeah,
Hmm.
they're very characteristic. They're just simple water density with really no perceptible wall, and they just kind of hang out. If they're a single one, if they can get to them, they can resect them, but um, you got to always do a source control. All right, so this was kind of a cool finding. This was a patient came in the ED for chest pain or something and looking for PE, didn't come out with much. But notice this stuff going on here. And the first thing you might think is this an elastofibroma dorsi, right? It's deep to the latissimus. It has some soft tissue density, but you have to notice a couple things. First of all, it's got these little linear things coming off it, like sort of serpentine, and also there's all these little punctate calcifications, and that's not typical of a elastofibroma dorsi. Those are usually solid with the kind of fuzzy edges there. And if you follow it down, let's see, we can follow it anteriorly here. It goes way up towards the scapula. And so this is not what that is. And indeed, this had, it turns out, digging around a little bit, this had been previously evaluated. But on this, see if I can get the right sequence here. Here's a post-contrast MR, and you can see there's a lot of enhancement in there. And even without the MR, I think we can be pretty confident that that this is a vascular malformation. I'm looking for see if I have a T2. Here's just an axial to show again that all that enhancement in there. So these are all vascular channels in there, and the presence of phleboliths tells you it's a slow flow lesion there. It's just hanging out there doing nothing. This had been previously diagnosed. It's just had to get some older imaging to just look at this, but sort of if it's not doing anything, a don't touch lesion. So a slow flow vascular malformation characterized by fat, vascular channels, and phleboliths in there, not an elastofibroma dorsi.
So is the fat part of it? Is the fat part of it, Jeff, or is it just?
Well, I believe so. I mean, because sometimes we call these hemangiomas and things, and they often have fat in them. I've seen one in the mediastinum, and way back when we actually reported a case, a patient had one in his mediastinum that drained into the pulmonary vein. He presented with a stroke, and so that one, of course, had to be treated. But my understanding is, yes, there is fat admixed in these things, and they often have these little channels in there, and you can see them anywhere in the body. MR is a good way to look at them if need be, if they're going to, especially if they're going to decide to treat one. But like one like this doesn't really need treatment. I'm not sure why the MR was done at some point, but there must have been some questions about them. And then they can embolize them depending on what they're draining, if they're causing problems, often in multi-step procedures because they can have a lot of flow. But you can see this one isn't really recruiting any major vessels. It's not like it's a big fistula or a shunt. So it's probably just, I suspect it's coming off some small muscular arteries.
So Jeff, would this have been called a venous tumor before? Like some sort of angioma, or
yeah, sometimes they got that name, or a venous malformation. But I think the term we use now is like low flow or slow flow, as opposed to like a true AVM that has very turbulent flow, sort of a like you might see in the brain where it can cause big problems. These generally don't. They don't embolize, and they're just there. And if they involve the skin, of course, they can have the funny discolorations and things like that. But this is what it looks like. But it was curious because it was in the right location for an elastofibroma dorsi.
But it's not. So we shouldn't consider this a vascular tumor then. We should consider a malformation.
Yeah, I don't know if there is if there's some proliferation. I don't know enough about these anymore. The names keep changing. If there's some genetic driver to these, this one is not part of a syndrome. There are some that can be, like Maffucci syndrome. You can get them associated with a bunch of, I think, enchondromas in the bones. And then there's some of these other named syndromes that are associated like that with different types of vascular malformations. But no, I don't think this is like any malignant potential. It doesn't need to be resected or anything like that.
All right, thank you.
Yeah. All righty. Well, that is what I got this week.
Okay.
Well, thanks for sharing the cases, Maya and David. And yeah, great ones. I'm curious to follow up that your CTD one with the cystic stuff.
Yeah, definitely. Yeah, I put the link in the chat. It's a fairly old one, so it may or may not download. But if not, feel free to contact me. I can try and get a PDF version of it.
I can probably get it through our library. David, if you have trouble getting it, let me know. I'll send it to you.
Can you? So I'm not seeing the chat part, and can you?
I'll send it to you. I'll send it to you, David.
All right. Perfect. Thanks, everyone.
All right.
Thank you all.
Bye-bye.
Bye.